Hi, this is Professor Johnson with the third installment of the edema management lecture. We're going to be talking today about some of the implications of treating the clinically complex patient. Of course, we went over the anatomy and the function of the lymphatic system, and we followed that up with talking about some of the concepts of how it is that we move edema through the body. Now it's time to talk about those patients that we will be seeing and some of the clinical complexities that we have to be aware of. So although edema management and manual lymph therapy are minimally invasive, there are some critical precautions and contraindications that must be observed to protect our patients. One of the first is understanding the difference between venous insufficiency, arterial insufficiency, and if it stopped there, I think the world would be a wonderful place. However, there are also patients who have a combination of venous and arterial insufficiency, which are referred to sometimes as mixed insufficiency. With venous insufficiency, you see swelling that's the result of failure of the venous return system. And so the fluid pools in the lower extremities as the veins fail to be able to return the fluid back to the heart. These patients will often describe that they get relief with elevation of their extremities. So as the day progresses, gravity continues to pull fluid down into their lower legs. And so when they can elevate their legs, the edema leaves or starts to dissipate, and so they feel physical relief with elevation of their extremity. Secondly, these individuals tend to have a dusky colored, kind of a bluish gray, dusky coloring to their lower extremities. And these patients will almost always, if they're going to develop wounds, develop those wounds superficially and in the shin area, kind of between the malleolus and the knee. And so that is the area where you will see the wounds developing. And the wounds are very, very superficial in nature. They look like somebody took a piece of cauliflower and pressed it down against the skin. And you'll see this kind of diffuse borders and rough erosion of the dermal layer. So this would be a hallmark example of a venous insufficiency patient who, again, you can see kind of that kind of dusky, dull hue to the tissues. You see that the wounds have developed almost exclusively in the leg area between the malleolus and the knee, and the wounds have, some of these have been healed over, but you can see the scarring from previous wounds. You can see some of the active wounds, and they have very diffuse borders. And again, if you were to see them in real life, they look very uneven surface, pockmarked, like somebody took a piece of cauliflower, like I said, and pressed it against the skin. These patients also are suffering from a condition that this darkened area right here that you see is caused by what's referred to as hemosiderin staining. And hemosiderin staining is that when the fluid in the tissues becomes so overloaded, the capillaries themselves are actually stretched and ripped apart, and you have red blood cells that actually pour out into the interstitial space. And then as the body breaks down those red blood cells, you're left with kind of an ochre color in the shins, which is referred to as hemosiderin staining and is the equivalent of tattooing of the tissue. Eventually, patients who progress and maybe get their edema under control, this staining will never leave. It'll fade over the years, and just like other metals. The iron content in the tissue will cause that reddish color to fade and eventually form a rustish brown color of staining. Here's another example, similar picture from the patient that I described for you and showed the progression of edema reduction. This patient, again, classic symptomology of venous insufficiency, kind of a dusky coloration to the tissues, hemosiderin staining, along with wound development very superficially and between the malleolus and the knee. We're now going to switch gears and talk about arterial insufficiency, where you will see some swelling and symptoms that occur, but you also have occlusion of the small arteries and arterioles. And this is a significant difference when it comes to treatment of these patients. One of the things that these patients will describe subjectively is that they get relief with lowering their legs or decreased activity, because the increased activity demand, their body cannot keep up with the circulation demands, and so they end up having pain. Again, as we talked about in the cardiac unit, and angina is heart muscle pain as a result of lack of oxygen. You can also see claudication pain in muscles, particularly in the lower extremities, from lack of oxygen as well. And so these patients are patients who, when they are in bed at night or when they've had their legs elevated for a particular period of time, will say, "Oh, my legs just feel so much better when I can hang them down over the side of the bed, and boy, do they feel better." These patients characteristically develop deep circular wounds that look like the equivalent of what's referred to as a punch biopsy, and these wounds are very round in nature, and they tend to be very deep, and they tend to be located over bony prominences. And what's happening there is that because of the lack of oxygenated blood, when the patient is lying down or sitting with their leg pressed against something, there's not enough oxygen that gets into the tissue, and so there is tissue death between that bony prominence and the surface that occurs. These patients also have what's referred to as rubor of dependency, which is that their ankles and lower feet will look fire engine red when they are in a dependent position, and when they are elevated, their legs will blanch very rapidly. This rubor of dependency is caused by the body knowing that it is needing oxygen. The localized tissues are dilating and trying to get as much blood circulating into the tissue bed as possible. And so that rubor or flushed look is occurring. However, the constriction is happening further up in the artery, preventing the blood from flowing through the tissues as it should. Another classic symptom or sign of arterial insufficiency is hair loss. These are patients much more noticeable typically in men, but also noticeable in females if they've stopped routinely shaving their legs. And hair follicles are particularly sensitive to needs of having oxygenated blood supplying them for hair growth. And so these patients will appear that they have been shaving their lower legs or ankles in comparison to the rest of their leg. And I often describe this similar to, for those of you who've done any alpine hiking or have been up in mountain ranges, there is something referred to as the tree line. And you will see thick forest growth up into the point where the environment is too hostile for the growth of trees, and above that line, there are no trees growing. Similarly, you will see this with hair loss, and I think I have a pretty good picture in this presentation to demonstrate that. And then finally, the ABI is the gold standard. All of these things are great things to look for. However, if there's any suspicion of there being arterial insufficiency, the ABI is the gold standard, and it is a measure in comparison of the lower extremity blood pressure in comparison to the upper extremity blood pressure. And I have a slide on that a little bit further in the presentation here. So here's a classic example of the lack of hair growth. This individual did not shave their leg, but you can tell the extent of where their arterial insufficiency is interfering with the hair follicle growth. And below this point, it looks as though the person shaves their legs, but they do not. Another classic example of arterial insufficiency, round, deep wounds. Oftentimes these are black and covered with eschar, and they are located over bony prominences. And again, you don't see them between the ankles and the knee. You see them in areas of bony prominence, and you end up with significant eschar. Hopefully you're able to see this in the presentation. My slides, hopefully in class, will reflect it as well. But this is the same person's limb in a dependent position and in an elevated position. Ruber of dependency, seeing the blanching of the tissue in that elevated position, and then seeing that redness appearing in the dependent position. So the ABI, again, is the highest systolic pressure of the dorsalis pedis and posterior tibial arteries in the lower leg, divided by the highest systolic pressure of the brachial artery. And so an example, typically in a normal population, the lower leg, because of gravity, the systolic pressure in the leg should always be greater than the systolic pressure in the upper extremity. And so again, a typical example, if the person's arm systolic pressure is 125, the leg is 130, you get a ratio. That number should always be greater than 1 in normal populations. And we typically start to define arterial insufficiency when that number starts to get lower than 0.8. And I've seen varying between 0.8 and 0.7 at various facilities, depending on how they characterize it. But know that this number, when it's normal, should always be 1 or greater, because normally your systolic blood pressure in your leg should always be higher than what it is in your upper extremity. Unfortunately, as I said earlier, not all of our patients end up with just venous or just arterial insufficiency. They typically have some of both, which is often referred to as mixed insufficiency. Also, the development of fibrous tissue and lymphedema can result from years of untreated swelling and edema. And so patients with acute venous insufficiency, the body over time can fibrose that liquid we talked about in one of the previous lectures, that the body doesn't like that loose fluid rolling around in the tissue, and so it will gelatinize that tissue, and there'll be fibrotic changes to the tissue, and as a result there can be damage to the lymphatic system, permanent lymphatic damage, permanent tissue damage that results after years and years of untreated venous insufficiency. So here's a classic example of a patient who doesn't fit into that broad, that easy categorization of venous versus arterial insufficiency. This is also a patient that's easily missed if you were to not lift up their pant legs during an initial assessment. So you are seeing a little bit of that hemosiderin staining between the shins, but you're also not seeing that fluid overload. Instead, you're seeing some muscle wasting, you're seeing some development of some deeper wounds. And so, again, these type of patients become a little bit more complex in terms of diagnosis. And so the gold standard with patients like this is to always get an ABI completed so that you have a sense of how significant, if at all, their arterial insufficiency is. Just a close-up of the same patient with some of those deeper wounds and some of the unnatural look of that limb compared to a typical venous insufficiency patient. So what are some other clinical implications for treatment related to precautions? Diabetes is certainly a thing that you want to be cautious of, because you're going to be moving lymph fluid around. You're gonna alter the beat frequency of that lymphatic system. You're gonna alter the uptake of glucose, and so if the patient is poorly managed in their blood sugar control, they can sometimes have complications related to some of the edema massage that is performed because of that metabolic factor. We are not going to be doing upper extremity edema management in this class. It's beyond the scope of an entry-level education, but as you get out into the community and are practicing as a PT, you may take additional edema management courses or learn to treat, become certified yourself. Carotid stenosis is always a concern if we're going to be doing edema management in the upper extremities. For patients who are menstruating and or suspect that they may be pregnant, treating in the abdominal area should be avoided. There is no cause for concern with pregnant patients beyond the fact that the United States is a very litigious society, and so we typically try to avoid anything that may be construed as having affected the outcome of the pregnancy. Related to menstruation, warning your patient that the things that you're doing with edema management are going to cause increased fluid uptake, and there have been many cases of increased menstrual flow following edema management treatments. And obviously the last thing you'd like to do is to cause your patient to have either an embarrassing accident or some type of undue concern because of the sudden increase in menstrual flow. And so warning them ahead of time that if they are menstruating, that they may see some increased flow while undertaking these treatments. Orthostatic hypotension. Obviously, with moving fluid around, we also can affect the fluid balance in the body, and so patients with orthostasis certainly need to be cautious with those patients. And when you finish an edema treatment, you don't just let them stand up and walk across the room. You'll want to have them sit up for a while, let their blood pressure adjust. Patients who have minimally controlled or controlled congestive heart failure, renal disease, or hepatic disease can be treated cautiously. This is a change from when I first became certified roughly 12 years ago in edema management. These patients were always contraindicated. If they had congestive heart failure, if they had renal disease, we didn't treat those patients. Now they're being treated and actively treated because of the good that can be done in terms of restoring function. And with patients, for instance, who are in congestive heart failure or have renal disease, the mobilization of the fluid with the use of a diuretic to help remove that fluid can certainly assist in restoring function and restoring mobility in conjunction with that patient getting healthier and able to return to home if they're hospitalized or in a skilled nursing unit. It's always good to be cautious when there's active chemotherapy agents or there's been like a steroid injection performed. Oral steroids, this is really not as much of a caution. However, if a patient has had a local steroid injection due to some type of inflammation, the techniques that we will be using would be facilitating the movement of fluid, whereas the injection of the steroid was meant to be a localized effort. There are some contraindications, times when we just don't treat patients. If that patient has an active infection or fever, we can very easily spread that infection around. If that patient has an acute DVT or acute case of phlebitis, there is that risk of pulmonary embolism. Neutropenia is certainly a risk that whatever sort of infection, bacteria, things that are being moved around in the system, if their white count is just too low to handle that is a contraindication. If that patient has uncontrolled CHF, renal disease or hepatic disease, we would withhold treatment until it is under control. And finally, some active or untreated foot fungus or eczema, you can spread that infection around. So some recommendations prior to engaging in treatment of patients with any of these conditions or symptoms. It's important to make sure that they've consulted with the appropriate physician or specialist and carefully review your proposed plan of care and weigh carefully what's the potential benefit from the treatment versus what is the potential risk. And based on that risk benefit analysis, you can determine whether or not it is appropriate to undergo the edema management treatment. If you do elect to proceed with treatment, care certainly should be taken to closely monitor signs and symptoms, and you should make every effort to educate your patient and caregivers of the importance of compliance and self-monitoring. A good example of this is if you have a patient with controlled congestive heart failure and you're going to undertake some edema management with their lower extremities and be pushing fluid back onto their system, you would certainly want to alert the nursing staff who is maybe monitoring that patient that, hey, can you do, ask them, can you do me a favor? Can you monitor this patient for, increased breath sounds to show that there may be fluid pooling in the lungs as a result of the edema reductions in the lower extremities, or any other type of monitoring that you want to request of them. Certainly keep physicians and other healthcare providers updated of progress so that they know what it is that's being done and how it's being done. Okay. Sorry, had a small technical challenge there. I think we're back in operation. So edema management for the lower extremity. Manual lymphatic therapy, or MLT, is a generic term for the lymph drainage massage techniques that we're going to be teaching you. And manual edema mobilization is another term for lymph drainage massage. So MLT, MEM, the name isn't as important as understanding the techniques. And so we'll get into that. The theory behind these techniques is that we are providing a gentle manual manipulation that's going to facilitate those lymphangian smooth muscles to contract, resulting in an increased speed of fluid transport. So if we can increase the beat frequency of the lymphatic system from that 10 times per minute to 30 times per minute through our manual stimulation, we can increase the amount of fluid being absorbed by the tissues. That manual manipulation is going to get the lymphatic system to move congested lymph from that lymphostatic area to a healthy functioning lymphatic quadrant. This is analogous to the circulatory system. Keys to effective edema treatment. Remember the two S's, slow and soft. We start proximal, so where we want the edema to go, and the thought is we want to remember to uncork the bottle. So we want to start with a patient. I'll move us back up to a picture of a resident here. So if we want the edema to move up the leg to above the knee where we aren't seeing a lot of edema, we're going to want to start up here on the leg, starting proximal, and we're going to want to work our way down the leg, kind of stimulating the fluid uptake so that these areas are primed to absorb the fluid as we work our way down the leg, even though the most swelling may be down here in the lower foot area. We're going to start up here, starting proximal, and then work our way down so that then we can flow that fluid up the leg and out of the tissue. And I think the key thing to remember is that effective treatment is stimulating the body to actively transport fluid. We are not physically pushing or moving the fluid. And so the technique is light and soft, and it's very, very gentle to the point where you feel like, how can this be really doing anything? But largely what you're doing is trying to stimulate that lymphatic system to move fluid. Certainly always take into account patient comfort as well as privacy. These techniques are going to be performed in areas of the body where patients may not be entirely comfortable with being touched, especially if you don't tell them what it is you are about and what it is you are doing. Maintain your awareness of body postures and make sure your positioning is good, because the other part about this type of therapy, very similar to some other manual techniques, therapists who practice in clinics where they do this all the time, this is a very fatiguing technique, and so you have to be very, very careful of your own body postures and making sure that you're positioned in a way to protect yourself from strain and injury. The other likelihood is these patients have swelling, so their limbs are very heavy, their bodies do not move the best, and so there's that tendency to put yourself in an area of stress and a potential for injury by attempting to treat them. And then certainly always observe universal precautions to protect both you and your patient from risk of infection. So the techniques that we're going to talk about, and we will do a demonstration in class, is the basic U. And again, we will be clearing by starting proximally, and we will work our way down the limb, and then we will flow. So we're going to clear our way from up above, down the limb, and then we're going to flow our way back up the limb. At the lymph nodes, which are generally found in the articular folds, we're going to add just a little bit of what we refer to as an oomping of those nodes, because the force that it takes to move fluid through that filter is generally increased. And so it'll be a little bit of increased firm pressure in the articular folds as a way of helping overcome the lymph nodes. So what we generally start with, whether it's upper extremity or lower extremity, is that we start in the area of the abdomen, which is where the cisterna is located and where there is a large repository of lymphatic system collaterals and connections. And we do the first technique, which is clearing and flowing the cistern. This is sometimes referred to as the cummerbund because it looks like a cummerbund that sometimes men will wear when they're wearing a tuxedo. So clearing and flowing the cistern is the first step. And we usually combine this with some diaphragmatic breathing by the patient. You guys all went through the pulmonary units, so you're familiar with diaphragmatic breathing. And here it is again, chance for you to practice those skills. And so we start by clearing, and we do 5 repetitions in that U shape, where the U is always opening like a cup toward where you want the fluid to go. And so we make that U shape 5 times. We then slide out to the side and do 5 repetitions. And then we slide out again to the side and 5 more repetitions. We then proceed to flow. 1 repetition, 2 repetitions, 3 repetitions, 4 repetitions, and 5 repetitions. And so we teach people the 5 and 5 technique, which is we do 5 clearing movements in the same area before moving out. And then we do 5 flowing repetitions, which are done in sequence. Once we've opened up the cistern, we're then going to move to clearing and flowing our first segment. So the cistern has been opened up. That is now primed, ready to receive increased edema. We're now going to move to the inguinal area. So this is going to be that first segment. And so we're going to do some clearing, and then we're going to flow from the inguinals to the cistern. The next segment is the upper leg. And so we are going to start proximally, and we are going to do our clearing. And now we're going to flow. Again, we will do a demonstration of this in class, and I will show you some of the techniques based on the size of the person's leg, how it is we then clear and flow some of the lateral aspects of the leg. But picturing this segment from the knee up to the inguinal area as the interstate or the superhighway of where we want the fluid to be traveling, and encouraging all the fluid to go into that area. The next area is the popliteal area, which is directly behind the knee. That area, high incidence, high concentration of lymph nodes, so we're going to put a little bit more pressure on that area. And then we're going to flow out and up the side over the top of the knee. Again, so popliteal area behind the knee, out and up to the top of the femur. The reason being is that the primary flow for the lower leg is in the posterior portion of the leg, whereas for the upper leg, the major flow area is the anterior portion of the leg. And I think that makes sense when you look at it anatomically. The anterior portion of the leg is essentially your tibia with some skin over the top of it. And so clearing and flowing the lower leg up to the popliteal area and then through into the femur. Again, diagram of that lower leg, clearing, and then flow 1, 2, 3, 2, 2, 3, and so on. And so that would be from the ankle to the knee segment, followed by the foot. And again, just some diagrams of how that fluid is moved up the back of the leg into the popliteal area, at which point we want to bring it around to the front of the femur and stimulate the anterior part of the femur. Some things to think about. Exercise is an important adjunct to the manual lymph techniques, and those exercises should be performed throughout the process of clearing and flowing the fluid from the patient's extremity. And I'm going to do a demonstration of these techniques in class and show you how the clearing and flowing combined with exercise works. And those exercises should follow that process from one segment to the next. There's no magic set of exercises. All you need to do is use your creativity and critical thinking. And we talked earlier about getting patients to buy in early to the process. As I show you some of the techniques, I'm going to demonstrate to you some of the patient self-massage techniques as well as the exercises that from the very first day that you treat these type of patients, you want to make sure that they are participating in the process and realizing that this is going to be a lifestyle change for them. And the spokesmodel who allowed herself to be covered with marker, she was invited to an event, not knowing what role she was playing, is my wonderful wife, Julia Johnson, who you guys had a chance to meet for the speech therapy pulmonary hygiene lecture. And so ultimately, she's encouraging you guys now. She did her part. She wants you to practice the techniques. And so again, in class, we will go over some of the high points from these 3 lectures, and then we will proceed with demonstrating the techniques themselves in class. Thank you, and this concludes the 3rd part of the lymphedema edema management lectures.